called me. It's my pleasure and honor to be here to talk a little bit about the prevent risk prediction equations and prevention of cardiovascular disease in 2024. So I'm going to start with a bit of an outlandish exercise and ask you all to imagine a world free of heart disease. As fantastical as that sounds, I will posit to you that it's probably more likely than my children achieving their dreams, which is to play for the Boston Celtics. At a 1 percentile height since birth, they are probably not going to be NBA players or even play for their elementary school team. But I do think we have the tools today to be able to at least get closer to this than we are right now. So what do we need to achieve this? The first is really understanding the contemporary burden of cardiovascular disease and its subtypes today. Second, determine who is most likely to develop cardiovascular disease and its subtypes. And third, implement available, highly effective therapies to reduce the risk of cardiovascular disease. I think we have the tools we need. So what do we need to actually accomplish this? This will set us up for today's outline. First, describe the evolving burden of cardiovascular disease and its subtype. Second, discuss current approaches to risk prediction for cardiovascular disease and its subtypes. And third, review the available evidence base and the gaps that exist for risk-based prevention today. So taking another line from Shakespeare, what's past is prologue. If we look back at the last 100 years, we see this rise of heart disease that occurred after the influenza epidemic of the 1920s. And at that time, Paul Dudley White, who was one of the founders of the American Heart Association, which we just celebrated its centennial founding, said, we know the hypertension may be an important compensatory mechanism, which should not be tampered with. We're even certain we could control it. To get things back just a few decades ago, we didn't even think we should lower blood pressure because it was a compensatory mechanism. And now we still seem to have some resistance to lowering risk factors, even though we can effectively do it and continue to achieve lower and lower risk factor levels. Fast forward a couple of decades, the Framingham Heart Study is established for the rise of the heart disease epidemic, and then the term risk factors is coined. And you start to see this subsequent decline in heart disease mortality, which may or may not be causally related to heart disease. We can have a discussion about causal inference and how we might want to attribute that to the founding of the Framingham Heart Study. But we see this continued decline over time and success in preventing heart disease with the availability of preventive therapies. We fast forward another couple decades, and really in the last several years, we see continued declines in ischemic heart disease mortality, but a plateauing and a reversal for heart failure mortality. These are graphs for age-adjusted mortality rates from 1999 to 2019, shown by race and ethnicity, where we see this pattern of ischemic heart disease continuing to show progress, but slowing down, and heart failure starting to increase. So we're seeing a shift in the type of cardiovascular disease that we're seeing. In addition, no matter the positive progress we've made, there's a continued gap with non-Hispanic Black individuals having much higher mortality rates that continues to be persistent without much narrowing. So why are we seeing this? This is not a surprise to anyone in this audience in terms of the cardiometabolic burden that we're seeing. Rates of obesity are increasing. Hypertension is poorly controlled. Rates of prediabetes and diabetes have increased significantly. And amidst all this, we know that having these risk factors portends worse cardiovascular outcomes, not just in the short term, but in the long term. These are seminal lifetime risk data from the Framingham Heart Study that show the presence of any risk factor by the age of 55 is associated with a higher lifetime risk of cardiovascular disease. So over the next 30 years, that risk can be well predicted based on the number of optimal or suboptimal risk factors. In fact, this can be really helpful when we think about the time horizon for risk prediction as well. If we look at 10-year and 30-year risk estimates, we know that both of those together could be most helpful. These are data from NHANES that show population-level distribution of cardiovascular disease risk by age. The younger someone is, the less useful 10-year risk estimation is. That's not a surprise. They're very unlikely to have heart disease in the next 10 years. But 30-year risk can be very helpful, and it can better stratify. In fact, when you look at the red bars, it actually accounts for a lot of high-risk individuals who are young. In fact, 3/4 of individuals who are at low tenure risk have high lifetime risk. That's risk that's greater than 40% of developing heart disease over the next 30 years. Amidst all this, we also know that work led by Dr. Wadera and colleagues here that risk factor burden is increasing in young adults, particularly those 20 to 44, where previously we didn't have risk prediction tools to even be able to incorporate these risk estimates. We know that obesity has increased from 33% to 43% over this 10-year time frame, and diabetes has increased from 3% to 4%. All of this together shows no sign of stopping, and work led by Dr. Kazi and colleagues for the American Heart Association show increasing projections, with nearly 61% of US adults estimated to be living with obesity by 2050. 81 million people will be living with diabetes, and all of this will account for $1.8 trillion in healthcare expenditures. So courtesy of AI, I have this massive tsunami that we are in the midst of for cardiometabolic disease. And what do we need to do to really change the tide of this tsunami of CKM in the United States? And I'd argue that we need a new prevention paradigm. Specifically, these complex interplay between these axes of metabolic risk, chronic kidney disease, and cardiovascular disease that together are acting synergistically to lead to higher risk of cardiovascular disease, as well as earlier onset. We're seeing younger and younger individuals with cardiovascular disease. So now that I've made that very depressing pitch, we'll go back to the hopeful part of the conversation. We have a much better scientific understanding of the interplay of these conditions. We have multiple novel therapies, and many of these therapies actually impact metabolic, kidney, and cardiovascular health together. So we have this opportunity right now. And this was really the genesis for the Cardiovascular Kidney Metabolic Syndrome Presidential Advisory and Scientific Statement, that we were able to think through and try to understand how can we put these pieces together and be able to help not just define this construct, but also use it to act upon it to reduce the risk of cardiovascular disease. And so we came up with this definition, which took actually much longer than you would imagine for how simple it sounds, of how do you come up with something that is actually translatable and shareable with something that is this complex. So in the most simplest term, CKM syndrome is a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity that together lead to poor health outcomes. We all know how often these things co-occur and that they don't happen in isolation. So we need to think about them holistically. And that is essentially what led to this overarching conceptual diagram that shows the CKM stages, starting from 0 in the absence of metabolic risk factors, 1 with overweight or obesity, 2 with metabolic risk factors, 3 subclinical disease, and 4 cardiovascular disease that exists with signs and symptoms. Even within this qualitative framework, we knew early on in the discussion that we needed quantitative risk estimation alongside it. And that was part of the definition for stage 3 from the beginning. There are individuals who have not yet manifested cardiovascular disease who may be at just as high risk. So this risk equivalent idea that originally had started with the idea of diabetes being a risk equivalent, but understanding that quantitative risk, somebody that has a 20% risk prediction over the next 10 years, is almost as a high risk as somebody who's already had an event. So if we think about generally, people once they've had coronary heart disease have about an event rate of 2% per year. About 10% seems about where we would want to put that. And so if we borrow again from Shakespeare, who were not just intelligent playwright, also perhaps predicted the future of cardiovascular disease, he would have said, you can look into the seeds of time and say which grains will grow and which will not. You can perhaps identify how to most effectively prevent disease. And this is really conceptualized here in this figure, where what the goal of primary prevention or this risk-based paradigm is to match the intensity of our therapy with an absolute risk. So if you have 5 people in front of you, you don't want to treat all of them with your therapies, but you want to identify who's at highest risk and high risk enough to benefit from that therapy or intervention. And this paradigm has really been around for more than 3 decades, when it was first actually described at the Bethesda conference in the late 1990s as this idea of using absolute risk assessment quantitatively to match the treatment benefit of an individual. So we think about it since then, in the next 3 decades, guidelines have endorsed this and broadly accepted and adopted this idea of risk-based prevention, not just for cholesterol, which is originally where it was introduced, but also for high blood pressure in 2017. In 2018 and 2019, cholesterol and primary prevention reiterated this idea of using risk prediction. And most recently, in 2022, heart failure joined on as well and said we also should be assessing for risk in heart failure. And so you see this broadly across cardiovascular diseases, but what remains missing is a harmonized approach across all of these guidelines that allows us to do this in one way. And that was really this next step within the CKM Science Advisory Group, was to say, how do we now think about what we need to be able to develop a multivariable risk prediction equation that allows us to harmonize all of these approaches for cardiovascular disease prevention and account for where we are today in terms of the risk factor burden, the treatments that are available, and our understanding. And so we came down to 4 key principles that we wanted to address as we were developing these new equations. First was to make sure that the equations we were developing were able to be generalizable to the diverse and contemporary population of the US that we see today, specifically knowing that prior risk prediction equations had largely relied on white populations or just white and Black adults, and knowing that's not where the United States is today. Second was to expand the utility and relevance to the full armamentarium of preventive therapies. We were moving beyond a statin-centric approach that just focused on lipid treatment. Third, to align our predictors and our outcomes with this growing burden and understanding of CKM, specifically incorporating kidney health as well as heart failure as a key outcome. And fourth, to really think about this extension of the time horizon, knowing that we needed to think beyond 10 years if we wanted to be most effective and impactful and include younger adults with that growing burden of cardiovascular disease. So all of this led to the development of the PREVENT equations, or predicting risk of cardiovascular disease events. The scientific statement outlined the rationale, and the methods manuscript goes through the details of the derivation and validation of the equation. So just a quick overview of what went into the equation development. We have the population, the predictors, and the outcomes. Importantly, the population really built on the progress that the pooled cohort equations had developed a decade earlier by using observational research cohorts, but also incorporating electronic medical record data to really be able to broaden the inclusion of large data with over 3 million individuals that were used in the derivation and 3 million in the validation. The predictors that were incorporated included those traditional risk factors. We largely know what causes heart disease, so it's not a surprise to see blood pressure and cholesterol and diabetes and smoking status, but also incorporated kidney function and statin treatment, knowing that the prevalence of these therapies has really increased. We also incorporated BMI with the growing obesity epidemic, and then developed add-on models so that when available or indicated, UACR, hemoglobin A1C, and social deprivation index was incorporated. For outcomes, as I mentioned, we incorporated that ASCVD as well as heart failure for a total cardiovascular disease outcome, as well as separate equations for each outcome. Shown here are the baseline characteristics for the derivation and validation. These equations were sex stratified, so you see the descriptive characteristics by sex. In both the derivation and validation, there was about a mean age in the 50s, spanning 30 to 79 overall. There's reasonable distribution of race and ethnicity, and risk factor levels are what you would expect for the general primary prevention population, with a diabetes rate of about 10%, statin treatment in the 15% range. So what were the results? How well did the model do? So in an external validation of 3 million distinct individuals, we see the number of events of total CVD, ASCVD, and heart failure. So we had a good number of events that we were able to capture. The C statistic, or the discrimination, which told us how well did we rank order people from higher to lower risk, ranged from about 0.74 to 0.83, so showing pretty good to excellent discrimination. And the calibration slope, which matches the observed to the predicted, where a calibration slope of 1 is perfect unity, hovers around 1 for each of these outcomes. So anytime you have a new model, the first and most natural question is how well does it compare to the current model for the pooled cohort equations? So we also tested the pooled cohort equations in the same sample. And not surprisingly, the C statistic is very similar, 0.73 to 0.77. We're using largely many of the similar predictors, so you get a similar discrimination. But the calibration is where the money is. And this is not something that was surprising to those of us that had seen reports in the last several years that the pooled cohort equations largely overestimate risk, and a slope of 0.5 suggests that the pooled cohort equations overestimating risk by about twofold. If you put in the same numbers to the pooled cohort equations, you get a risk estimate of about 10%. You're going to get about 5% from the prevent equations, and that is pretty consistent with right sizing where we are for contemporary event rates. The other thing I'll point out is that the correlation between the risk estimates, so how well do they track, was very high, so about 0.9. So the absolute number is what's being right-sized, but the general discrimination and correlation is very similar. So the calculator is available online for anyone who's interested to use it, and the URL is listed here with the QR code. And I'm happy to say we've been tracking kind of traffic overall, and we've seen over 80,000 individuals visit the site. And I think this is really helpful because we want to make sure that we can understand how well it's being used, who's using it, and are there other considerations as we think about moving forward with how to consider implementation. I do want to just do a quick overview. I shared some of the differences between pooled cohort, but also with Framingham risk. As we think about the evolution of risk prediction itself, it's really helpful to know that there's a lot of similarities. I think while prevent is new and there's a lot of excitement around it, I want to emphasize that a lot of what we're using are the same principles that have been applied to Framingham risk score, that have been applied to pooled cohort equations, and largely where some of these differences come from are being able to have a larger, more diverse, more contemporary population. So even though pooled cohort equations were published just 10 years ago, they largely relied on data from the 1970s. So when we think about that overestimation by twofold, that's where that comes from. And so being able to have a more contemporary data set allows us to have more accurate prediction. In terms of predictors, incorporating kidney function, being able to have some additional predictors when relevant, incorporating social risk, these are things that can help us refine risk estimation. And then outcomes, understanding that heart failure is growing in terms of the burden of cardiovascular disease gets us a more holistic sense of what risk is for cardiovascular disease. So I do just want to walk through a hypothetical example. This is not a real patient, but just to see how using some of the different inputs can actually change risk and how prevent, compared with pooled cohort equations, might be able to help you better risk stratify a patient in front of you. So a hypothetical 55-year-old female with a cholesterol of 200, HDL of 59, blood pressure of 122, not smoker, not on antihypertensive medication, and not on a statin medication, with a pretty normal GFR, so not an uncommon scenario in the US population, would have a risk of about 2.7%. But if you look at this patient and they had stage 3 kidney disease, that risk would increase to 5%. Or they had diabetes, it would be about 6%. But if they had both kidney disease and diabetes, you get an estimated risk of about 12%. This really highlights how important that kidney disease function can be in understanding risk. And this is very consistent with observational data that show that once kidney disease develops, the risk for cardiovascular disease increases significantly. And being able to now estimate that allows us to better understand what are the therapies that might be helpful. So I want to shift gears a little bit and talk about some of the nuances that went into the development of the risk prediction equations, some of the decisions that were made, and perhaps think about where we go from here. So specifically 3 key areas that I want to touch upon: race and social determinants of health and cardiovascular disease risk, the use of biomarkers to refine risk, and then this question about risk thresholds. So how do we actually use the risk prediction equations? Because calculating risk is only as effective as calculating it, which is not at all until you actually use it to guide therapy. So over the last several years, there's been a lot of discussion and thought around how race and bias play a role in clinical care algorithms. We know there are substantial disparities in terms of cardiovascular disease outcomes, but also treatment disparities. And the question is, how much of this is embedded within the equations that we use, knowing that within the pooled cohort equations, there were race stratified equations. So if an individual were self-identified as non-Hispanic Black, there was a separate set of coefficients that were plugged in compared to someone who identified as white. For those who identified as a race other than white or Black, the recommendation was to use the coefficients for white individuals. It's very, very binary and not at all reality. And it really still raises the question of why should race be incorporated into how we estimate risk or how we care for individuals. This perspective from the New England Journal of Medicine really spurred a lot of discussion around many of this, not just in cardiovascular medicine, but broadly in clinical care algorithms that are used throughout medicine. There was a systematic review that was supported by the National Academies of Medicine, as well as a workshop that really started to delve into questions of how do we best address this? Because just saying race-free, that we don't see race, is not sufficient either. We know that there is incredible amounts of bias, discrimination, structural barriers to healthcare access and treatment that influence these outcomes. So how do we think about this in a way that actually allows us to make sure that we are treating patients equitably? And I think one of the things that was really important as we were thinking about this for the risk prediction equations was the kind of this binary pull between knowing that we wanted to make sure that we didn't overestimate risk or underestimate risk in any individual group. And so one of the things we spent some time on was thinking about how do we best assess this? Even if race is not a predictor in the equations themselves, if there are other factors that we're accounting for, like blood pressure, which we know is systematically different between groups, risk of diabetes, risk of kidney disease, where a lot of disparities lie and often precede cardiovascular disease, can we capture that risk and still have good calibration, even without race being included in the equations? And so two things that we did was look at the calibration and discrimination. So shown here are the calibration statistics for Asian adults, Black adults, Hispanic adults, and white adults. And you can see that largely the calibration slope still centers around that line of unity, or 1, with slight underestimation for Black adults and slight overestimation for Asian adults. And I think some of this question that further is then propelled by this is Asian adults and Hispanic adults are not monolithic either. And there's a lot of variability even within those categories. And how do we continue to push and understand the differences there? I think the second thing that was helpful and important was to say, well, this is how the PREVENT model does, that doesn't have race-specific coefficients. Well, how well in the same sample does the pooled cohort equations perform? And so looking at the calibration there, we see again that overestimation by about 2-fold, but fairly consistently for each race and ethnic subgroup, where we see that range kind of between 0.4 to 0.57 across individuals. And I think it's helpful to go back and say, even though we know that in the PREVENT equation development, we did actually have inclusion of Black adults, Hispanic adults, and Asian adults, in the pooled cohort equations, it was just individuals who were white or Black based on their inclusion criteria from observational cohorts. So part of, I think, what we're able to accomplish by having a more diverse and inclusive population is to be able to have estimates that are broadly generalizable, that are more applicable to the diverse US population. I think the next steps are how well does the PREVENT equations perform and understanding further need for external validation. So we were able to pull together a team to look at this in the VA population, a very diverse sample, completely different from those that are generally receiving healthcare and commercial healthcare systems. And in over 2.5 million veterans, we see with a mean age of 60, calibration for the PREVENT equations are pretty consistent and similar across race and ethnic groups. Whereas again, for the pooled cohort equations, particularly at higher risk ranges, where you see that tail kind of drifting off, we see overestimation. In addition, colleagues at Kaiser Permanente, Northern California, have put together a cohort of over 2 million diverse adults. I don't think there's a more diverse sample of primary prevention adults in the country than in California, with large representation from Asian and Hispanic individuals. And you see, again, that line of unity in the dashed line with the different colors for the pooled cohort equations in red, which is far above the dashed line, The Kaiser Permanente has their own calibrated model that they call KPAR, as well as the prevent models for the base and the full add-on models, where you see, again, very good calibration overall for each race and ethnic group. I think the one that is the most off is probably the unknown race and ethnicity, which is quite unclear exactly who's included in that group and is the smallest group of all. So I'm going to shift gears a little bit and talk about that social deprivation index predictor that was included as an add-on variable. These are maps from a publication a couple of years ago where we plotted for Chicago, Washington, D.C., and New Orleans the age-adjusted prevalences of coronary heart disease, and then plotted the social vulnerability index. And you can see the heat map gradient. The darker areas have higher prevalence of coronary heart disease and higher prevalence of social vulnerability. So not surprising, they kind of overlap, right? Areas that have higher vulnerability have higher rates of disease. But, oh, you have a phone call, Rishi. Do you want to? Yes. Should I pick up? No. Yes, yes. The SNU does that. It's part of its new add-on. So looking at these maps, not a surprise, right? There's geographic patterning of disease and vulnerability. And so one of the things that we wanted to consider was, can we start to incorporate some of these social constructs and place-based disparities into the risk prediction equation? It wasn't part of the base model because we don't want to require it in case someone didn't have a zip code, in case someone had other challenges with housing stability or instability, which may be different risk-enhancing factors related to that, but included as an add-on. So when it's available, it can help better discriminate risk. I think a couple of things as we think about what that means in risk prediction itself. We use social deprivation index, but there's a variety of place-based measures. Sometimes I get asked, why SDI, why not ADI or SDI, or all of the different indices that exist, which continue to increase. I think all of them are trying to do very similar things, and this was the one that was accessible and the one that was available in most of the data sets that we had. So I don't think there's anything unique about SDI, and I think many of them perform similarly, but that's the one that we had available. I also think zip code, which is the level of geographic area that we worked with, is not ideal. I'm sure here in Boston, you could be in the same zip code and there's very, very different areas of social vulnerability. Same is true for Chicago. Same is true for many cities. But it was a starting point because there's also large variation across the United States that if you start at least even refining to that zip code level, which was the level of data that we had, it's really a starting point. And then third, I think one of the challenges with incorporating social deprivation or the social determinants of health is that it doesn't stop there. Part of the assessment is ensuring that we're also starting to think about this in our conversations and addressing social determinants of health. I've gotten asked, well, do you tell people to move if they're in an area of, high social deprivation? That is probably not going to fundamentally be the way we're going to address this, but trying to capture it, right? It's a surrogate of what we're doing. I think the other piece that gets asked a lot is, does this replace race? And I think that's a really difficult question as well, because it's a different measure of social deprivation than the influence of race, racism, and discrimination that exists in the United States. So I thought this quote was really helpful as we think about these questions, and they're really difficult questions and complicated things to address. And so this is a really wonderful book by Linda Villarosa, who said, if you really care about these issues and want to make a difference, you must not use race as a proxy for poverty or poverty as a proxy for race. They intersect and overlap fundamentally in the United States. But to really understand health of this country, you have to be more sophisticated than assuming that only poor Blacks are affected by this crisis. Look deeper and think differently. And I think we're trying to understand these intersecting domains and how they influence together cardiovascular disease risk, rather than trying to reduce it to something as simple as this. So shifting gears a little bit to talking about biomarkers. I think a lot of people here work on biomarkers. It's very important to think about how the different mechanisms might play a role. But in atherosclerotic cardiovascular disease risk, biomarkers have largely been disappointing from a risk prediction standpoint. So if we look at one metric of percent reclassified and net reclassification index for high sensitivity CRP, carotid IMT, ABI, and polygenic risk scores as examples, we see largely small movements for discrimination and net reclassification. In contrast, coronary artery calcium has a large net reclassification, and not surprising, it's measuring disease, right? So unlike biomarkers, which are trying to predict disease, it's measuring disease. And while these were all tested with Framingham or pooled cohort, I don't think it's going to be largely different for PREVENT. I think that work needs to be done. But because you're capturing a lot of the risk already, it's hard to move that discrimination further with biomarkers. So thinking more about where do biomarkers actually represent subclinical disease rather than predicting disease. And I think that's where perhaps thinking about how biomarkers might help influence risk of heart failure could be very different than atherosclerotic cardiovascular disease. And this is work done by Dr. Jen Ho and colleagues here that showed that biomarkers can actually help identify who might be at higher risk of incident heart failure, and particularly heart failure subtypes. The outcome for PREVENT was really looking at any type of heart failure. But as we start to get a better understanding of different types of heart failure and which biomarkers might be helpful, these are associations, but I think it might be more relevant, especially knowing the biology of where cardiac stress biomarkers like troponin or BNP might reflect evolving heart failure disease rather than just risk. So I think more to come here that is definitely going to be of interest. I'm going to shift gears to this question about how do we use risk scores and how do we define thresholds? Because I think this has led to a lot of discussion, particularly around the differences between PREVENT and pooled cohort equations, and if you compare the two, and what do we do with it? And so I think it's really helpful to actually take a step back, and we contributed this viewpoint to JAMA to try to outline how PREVENT changes our paradigm. So that first figure I showed you with matching the intensity of risk with the prevention efforts, I don't think that fundamentally has changed, right? And so one of the things that we wanted to focus on in this viewpoint was saying that although that foundational principle discussed in the 2013 guidelines is still relevant, the difference is that predicted risk can now be estimated with greater precision. So why does that matter? Well, I think it's important to think about where that 7.5 number comes from. We all anchor around this number of 7.5% for when we treat or when we should consider treating with cholesterol lowering therapies. And that was largely based on two things related to the net benefit of treatment. So if you have a moderate intensity statin or a high intensity statin and you assume a relative risk reduction of 35% or 45%, and then think about the potential harm. So this was the benefit, and it was matched on the harm to come up with that estimate. That number needed to harm was largely related to risk of diabetes. So in Jupiter, the risk of diabetes was about 3% over 10 years. And so accounting for other risks that may occur, they got to kind of a 5% range of saying 5 to 7.5. And then knowing even then that pooled cohorts overestimated, 7.5% became this number that was around what we would expect. And so if we backpedal that and say, well, we now know we can estimate risk more accurately for a contemporary population, well, perhaps between moderate intensity and high intensity, that number should be closer to 3 to 5%. So I think that is actually part of the discussion of saying the clinical trials tell us what the risk reduction is, tell us the potential for harm, and the risk prediction equation tells us how well we can how well we can estimate that risk, or how accurately we can estimate that risk to try to get at what's the right number. And all of this is probably a little bit oversimplified because nobody treats a patient based on one number, right? And we have other tools that help us reclassify, but where should these discussions start? So I think that could be helpful as well. Part of the challenge with any risk prediction equation and model is that it really then is waiting for the guidelines to start to provide practice recommendations. And I think this timeline of thinking about how the sequential following of guidelines following Framingham risk score with ATP3, ACC, AHA guidelines after pooled cohort equations, which were much more simultaneous, help us know that this is really what we're waiting for to best understand how to implement prevent equations moving forward. So my last Shakespeare quote, "It is not in the stars to hold our destiny, but in ourselves," is that there's a lot of excitement. There are so many new therapies that can be useful, that help us move beyond a statin-centric approach to cardiovascular disease prevention. We have SGLT2 inhibitors, we have GLP-1 RAs, we have non-steroidal MRAs with new data from finerenone that really help to highlight these drugs are improving kidney health, metabolic health, and reducing cardiovascular disease. But they all cost between $1,000 to $3,000 over a 3-month cost list price at least. And there's so many of them. And so how do we actually start to approach prioritizing, as well as understanding when to maximize therapy and who to treat with what? I wanted to use this example of GLP-1 RAs with work done by one of your superstar residents, Ivy Shi, who helped us try to understand what is the magnitude of individuals who might be eligible for a therapy like GLP-1 RAs. So if we think about the total eligibility across all of the trials that have been done, we get really an astounding number of 137 million. So, that's an incredible number of people that we would say would be eligible for therapy, and makes no sense to say everyone should be treated if it were even affordable. And if we start to break down who is eligible for cardiovascular disease, who's eligible for diabetes, who's eligible for weight management, we see a lot of overlap here. But I think one of the key questions within all of these indications is, what is the clinical trial data that suggests that there would be benefit, not just for immediate weight loss, but for cardiovascular disease prevention? And I think really what we have for that is 3 clear cardiovascular outcome trials: the SUSTAIN-6 trial, the SELECT trial, and the FLOW trial. They had very different populations, but you see here the all-cause mortality, CVD mortality, and MACE outcomes across these 3 trials are largely similar and just remarkably high. So over a 2-year period in SUSTAIN-6, which was individuals with diabetes and more than 3/4 already had prevalent cardiovascular disease, there was about a 9% MACE event rate in the placebo group. So if you think about 5-year risk for that, 9 times 5, 45, I'm not very good at math in my head, but 45% 10-year risk, right? In SELECT, which was people with prevalent CVD, there was an 8% MACE rate in about 1.2 years, so even higher event rate. And in FLOW, we see a 14% event rate for MACE, but these are individuals with diabetes and kidney disease. So if we start to think about primary prevention patients, go back to Ivy's Venn diagram of all these individuals, the trial data are talking about the top 5%, top 2% of highest risk individuals who either already largely have cardiovascular disease, and a very small group of individuals who don't, which sets up this question of how do we actually understand who is going to get benefit from these high cost therapies. And the same is true for finerenone, for SGLT2 inhibitors. As we think about these more expensive therapies, where is their benefit in primary prevention? And I think one thing that might be helpful is to start thinking about absolute risk reduction. So this is a schematic that identifies how we can think about absolute risk reduction. For any given therapy that has a set relative risk reduction, you have 3 individuals that have different baseline risks. So an individual in green that has low predicted risk, yellow intermediate, and red high predicted risk. And you see the delta from the same relative risk is greater for that individual that has higher predicted CVD risk, or that absolute risk reduction is greater. So one way to maximize or have the most efficient use of therapy, whether it's from a benefit perspective or a cost perspective, is to try to target those individuals at highest risk. And so I think this might be a framework that could help us conceptualize not just who to treat, but what therapies to use based on this crosswalk of absolute risk, predicted risk, and what relative risk and therapy may give. So this is completely simulated data, but depending on the therapy, if you know the relative risk of that therapy, whether it's 0.3 in orange, 0.4 in purple, 0.5 in blue, you can actually crosswalk an ARR of 2%, which is a pretty reasonable number, saying number needed to treat of 50, to what that predicted risk threshold should be if there's a direct correlation between the relative risk and the predicted risk. So I don't know that this is going to work for all therapies. There may be different harms where a number needed to treat needs to vary from 50 is not reasonable for something that's very, very invasive or very, very expensive. But it starts to set up a framework of how we can consider benefit in our discussions, moving beyond just a risk threshold, which work when you are just talking about statins and one drug, but we really have to consider multitude of agents and therapies. So I will conclude there with 3 key takeaways. Hopefully I've convinced you we are moving towards a CVD-free world, even if that goal continues to be aspirational, and understand that the burden and phenotype of cardiovascular disease has shifted. And we're seeing this growing prevalence of the CKM syndrome as kind of our predominant phenotype of cardiovascular disease, particularly among young adults, and there are significant disparities that persist. Prevent accurately and precisely predicts risk for total cardiovascular disease, for ASCVD, and for heart failure, and is able to do so in diverse samples of US adults with similar calibration by race and ethnicity. And third, future research should focus on external validation, understanding how individual level and place-based social determinants of health interact, and evidence-based implementation for statins and more broadly CKM therapies. I have all these asterisks here because I think it would be naive to say that there aren't huge things to consider and try to understand in terms of multi-level barriers with implementation, but that would be several more hours of discussion. So I'll conclude here with the optimistic viewpoint. Thank you so much for your time and attention. Happy to.
We have a ton of questions. Yeah. Great. I'm always surprised that family history of
yeah, just because something's in the model, I don't think it doesn't need to be asked. So it's a really good question and definitely something we talked about. Oh, yes. So the question was, should family history, well, why doesn't family history make it into these models and should we ask about it? Perhaps the latter being facetious. But I think one of the challenges with how we assess family history and how it's measured in cohorts when you're developing prediction equations is a pragmatic issue, right? It's really challenging to actually ask that question in a systematic way, get that answer in a systematic way, and be able to build it into a model. So I think that's part of it. I think the second piece of it is that there's a lot of qualifiers, whether it's family history, adverse pregnancy outcomes, premature menopause. You're going to have some sex-specific, factors in there that are important to ask and assess, but we don't need everything in the model for it to be relevant. So I think of family history as one of those things where when you get a good family history, when you're talking to somebody and you have a sense of it's really a premature driven event that is related to something in that family, well, a multiplier might be more helpful or a qualitative assessment might be more helpful than having it in the model. So I think pragmatically, but also this more qualitative approach makes it still important. Yeah.
How do we think about how to reach expenses? We talked a little bit about your how do we think about it?
Yeah, I think there's, yes, I will try to remember. So the question was around genetics. So we talked a little bit about biomarkers, polygenic risk scores, but broadly inherited risk, right? Coronary heart disease, particularly the heritability of coronary heart disease is 40%, right? Some of that is built into the other risk factors, but there are specific variants that make an individual more high risk. Like I think about FH or specific conditions that might make somebody from a monogenic standpoint more at high risk or from a polygenic standpoint. I think the challenge again with risk prediction is that quantitatively when the prevalence of something is very, very low, like FH, it's not going to move on a population level, the risk prediction, but the qualifiers and the more kind of risk assessment piece is still very relevant.
I have a couple of questions. One was in terms of the race-specific calibration that you showed us, is that for the model that includes STI or for the model that does not include STI? And how does that work, given that there are differences? So how does the equation capture that risk without STI? That's one. And then the second is your favorite question. How do you address the criticism that a lot fewer people are going to qualify for statins in this new world?
Yeah. So the first question in terms of the race-specific calibration results that I showed both within the validation set as well as for the VA and Kaiser, we're all using the base model. And I think it's really important to look at it in the base model without SDI first, because the SDI can be helpful, but is not a replacement for race. And so even though race isn't a predictor, part of what is captured are those other risk factors that are different. So if you had two people that had the exact same risk factor levels, they're going to have presumably the same risk. But we know in America, from a US population standpoint, on average, Black Americans develop hypertension 5 to 10 years earlier, develop diabetes 5 years earlier, develop cardiovascular disease 5 to 10 years earlier. So they have a higher risk and earlier onset that's getting captured by those things. The second part of the question was around treatment. And so I think that is that piece about thresholds. And so if you look at that 7.5 and take what was applied in the PCEs at 7.5 to prevent at 7.5, it will automatically be half as many people. But I don't think we're still in an era where 7.5 makes sense, given the multitude of data that we have around the benefit of therapy. And if we can actually predict risk down to that closer precision of 3. So I don't know what that number should be, but there's probably better conversations around 3, 4, 5. And then thinking about how can we better refine risk? Is it biomarkers? Is it genetics? Is it calcium? And using the tools we have now rather than saying it's a one number fits all.
Yeah. Rob?
A follow-up to that question, moving on the genetic side, maybe a third rail, but we know that individuals of self-reported Black individuals with Jackson Park are 80% the genome of Africans. Somewhere in California, kind of like 50-50, etc. Is there any discussion or to begin to adjust for ancestry just by genetic inheritance? Because all those individuals, all those cohorts we were talking about,
yeah.
Is that discussed? All people can do those.
Yeah, we talked a bit about genetics and ancestry, and I think at the time there's a pragmatic in terms of having access to that data, but I think a more philosophical question around it's not ancestry per se that introduces risk, but if there are specific variants. And so I think that's the question is, are there, for heart failure, for example, that TTR in individuals with West African ancestry has a higher prevalence? Or, yeah, exactly. So I think the question is, can we get to those variants and then better refine risk rather than, even if ancestry is genetically determined, it's still a reductionist approach around similarities. And so rather than using surrogates, get to the variants themselves.
None of this stuff works if patients don't come to the doctor or some sort of health practitioner. I know that both specifically the cardiovascular prevention visits are almost invariably wealthier, less socially isolated, et cetera, et cetera. You think on a policy level, there's some value in incorporating cardiovascular risk assessment, tying it to some of the social that like college application, grade school application, et cetera. It's just been versions of this for non-communicable, other non-communicable diseases haven't tried any places. Infectious. But what do you think? I mean, I'm not, obviously there's no simple answer to that. Thanks, but thoughts.
Yeah. Thank you for that question. So the question was, are there different approaches that we should be taking? And I think maybe moving outside the healthcare system for some of what we want to do for cardiovascular disease prevention. I think if we had an answer, it would be a lot easier to tell you what we should do. But I do think we need it to disrupt what we're doing. It is not working, right? We've been doing the same thing and it continues to not work. And there's a lot of different reasons for it, but there's a fundamental issue of public health not being a priority, as well as misinformation. I mean, like I think you gave the example of infectious diseases. The influenza vaccination rate in the United States is less than 50%, right? So if you have something that simple, that widely decentralized, accessible anywhere, free for anyone, is not getting used. I don't think it's going to be one thing, but rather thinking about this from multiple levels, multiple different barriers, and then as well as ensuring access. I think, to your point, even people who come to the doctor who have insurance get denied for cholesterol screening. We see this all the time, right? So there's structural issues, there's policy level issues, and there's public health issues.
When the vaccination rate is less than 50%, so in the hospital, where it's
Mandated.
required.
Yep. And that, so, but this is like the, you know, the tug and pull of, does the public trust to have mandates?
All right, in the last couple of minutes, you want to tell us what you're working on now?
One thing specifically?
Something that future direction. For your own.
You know, the last thing that I showed around absolute risk reduction, I think is really important to think about. How do we move forward? These new therapies, as exciting as they seem, I think, to your point, actually, if patients can't get to the doctor, if they can't afford the medication, if they can't get their medication consistently, then it's not really going to be effective. And we have all of these wonderful things that nobody can use, or largely most people can't use. So I think starting to understand how we can prioritize expensive and high cost therapies where we can maximize the benefit, and using observational data to try to understand how we can best match up that risk and benefit piece.
Thank you very much.
Thank you.